So some of you guys probably already know some of these things, but we're gonna go through all of them and learn how to do blood pressure and pulse and all those good things the manual way, okay? So body temperature, heart rate, blood pressure, and respiration rate are all indicators of general health. It's a baseline measurement of our vital signs. It's very important. We should do these before we start exercising. The most important one to do is blood pressure, okay? It's the most critical one to evaluate initially before you start activities with the patient. Measurements of patients' vital signs can be established to help with the goals of the treatment. It helps us kind of change our treatment plan and how they're responding to our treatments as well. Who should we check their vital signs? Your book says elderly people over 65, patients under 2, anybody that has general debility, if they have limited aerobic activity for several months or weeks, anybody that has any kind of cardiac issues, anybody that has had trauma or surgery, and anybody that has any pulmonary issues as well. So basically, you should be checking your vitals on everybody, okay? It's just easier to sum that up. Possible adverse reactions to activity. So people that start to have issues or should display some of these symptoms, right? So they'll have mental confusion, fatigue, they can pass out on you. They are usually less likely to respond to verbal or tactile stimulus. So like us talking to them, they might start to get like a blank look and not respond to us. They could become pale. They could also have decrease in their blood pressure. Their pupils can become restricted or dilated. They can lose consciousness, okay? Most of these are are caused by a lack of oxygen. That's the number one reason, okay? And then diaphoresis is excess sweating. So some people get nauseous if they're working out, but some people start to sweat an abundance amount. And now we all know that one friend of ours that sweats a lot, right? Yes?
So is this kind of stuff that happens normally, or is it like if you're in like PTA then it won't happen?
So you mean for like this could happen to you?
Yeah.
So honestly, people, and the book talks about exercising. Sometimes walking is literally exercise for our patients when they've been extremely sedentary. So if you saw any of these symptoms, you should stop your therapy, right? And we should be checking vitals at that point. So remember that somebody that has been in the bed because they were in a car accident, maybe they were in a coma, and they've been in bed for 3-4 days, they start to wake up and you sit them on the edge of the bed, and all of a sudden they get really lethargic or they start to sweat a lot, you should immediately stop what you're doing and you should address your vitals first and then see what to do from there, okay? So this could happen to you at any point. This isn't really like you didn't do your job ahead of time or something went wrong, right? This is just how they're reacting to the treatment. So, and you'll be shocked if you work in a hospital or you work in like any short-term rehab, any of the rehab settings, this limited exercise, like sitting up on the edge of bed, sitting over in a chair for the first time, walking, maybe like 3 feet, they can start showing these symptoms, okay? So they can come on and it's not what you would expect from like somebody that's an outpatient, okay? All right. So the excess sweating, just remember, like we all have a friend that sweats a lot, right? But this would be like all of a sudden the person is just starting to like, they're busting out in sweat and it's like, you're not that stressed and this shouldn't be occurring. You'll have that gut feeling that something's up, okay? So body temperature, an indication of the intensity of or degree of heat within the body. In the human body, body temperature remains relatively constant regardless of the environment. It will go up slightly if there's a warmer environment or slightly go down, but as a whole, our temperatures are pretty regulated, right? The normal range for a human body temperature is 96 to 99 degrees, with the average being 98.6, okay? Pyrex is when you have a fever, and that would be above 100, okay? And then hyperpyrex is 106 degrees or higher, all right? A person whose body temperature is elevated before the treatment, we should kind of be cautious with, because we don't want to overwork them and overload their system. So we need to be careful if they're already running a fever if we're doing something. So you might limit some of your therapy treatment that day. And then excessive temperature is measured, and the patient requires adequate periods of rest as well during the treatment, okay? A person whose body temperature is below normal, we also want to monitor them, because we got to remember that they might not go up as quickly, right? And they might not show effects if they were already lower. You have any abnormal case, or you need to use caution with them and talk to the physician, okay? So what are things that could affect the body temperature? The time of day. Your temperature is actually lower in the morning than it is in the afternoon. Your age, there is a tendency, there is a decrease, it's decreased slightly as we age. And so the younger person, like a 2-year-old, is going to be slightly elevated, okay, compared to somebody that's like in their 80s. The environment, I think we all kind of know this, but if it was hot and humid, our body temperature will be up just slightly. Like, we shouldn't be running a fever, but it'll go up just slightly, okay? Same with cold, it'll go down slightly. If they have infection, sepsis, you're gonna have a higher temperature, right? They'll be running that fever. Physical activity usually increases slightly, but then should plateau. We should not be able to get into a fever when we work out. Your emotional stress, can we increase it again slightly? The site that you measure it at, we'll talk about in a second, could give you a little bit of a variance as well. For us females, when we're ovulating, it will be slightly up, right? And then if you give the temperature, if you are monitoring it through the mouth, if they've drank something really cold or eaten something that's really hot in their mouth, that will also change the temp, okay, just a little bit. Sites used to measure our body temperature, so you can use the rectum, the axilla, sorry, I'm always like, these words, the ear canal, forehead, and the temporal lobe. Mostly what you're going to see out there working is going to be the ear and the mouth. You just use the thermometers for those two locations. It should automatically beep for you. We no longer use mercury because it's actually could be harmful to the patients. Okay, so all of them now are all used. The machines are what we use. Okay. The oral cavity is most commonly used, but the most accurate is actually the rectal cavity. All right. The least accurate will be the armpits of the axilla. All right. So we would prefer that we're not going to learn the rectal. Aren't you guys relieved? Did you think I would make you do that? Okay. Anyway, no. So we're going to use the oral cavity or the ear in our careers. Okay. So, yeah. All right. So for pulse, the pulse is an indirect measurement of the contraction of the left ventricle of the heart. It indicates the rate that the heart is beating. Okay. the movement of the blood in an artery, which can be palpated in various spots on the body. You can also listen to it with a stethoscope as well, if you want to. All right. The rate and frequency is usually beats per minute. Please don't abbreviate beats per minute. It's actually, we're not allowed to anymore in healthcare. You will see it quite a bit. The reason is there's actually a medicine that got abbreviated as well, so for the BPM. And so then there was actually an interaction because somebody had written that and they didn't know if they were talking about the drug or they were talking about beats per minute. So we're not allowed to use an abbreviation for this anymore. Anyway, though, for the normal range for us adults, we should be between 60 and 100 beats. Our infants, our babies, are going to be about 100 to 130 beats, and then smaller kids should be between 80 and 120. Okay. Factors that influence our pulse: the age. Older people, so 65 or older, they usually have a decreased pulse, and younger people usually have a higher one. Okay. Male pulse is usually slightly lower on average. If we looked at the resting heart rate, there should be a slightly lower than a female's. The environment, increased higher temperature will usually cause an increase, and decreased temperature. So if it was cold, your pulse should go down a little bit. Okay. Infection, usually, especially if you're septic, you're going to have a higher pulse just at rest. Physical activity, the pulse should normally rise with the intensity of the exercise, right? And then it should kind of plateau as the exercise intensity plateaus. And then if we stopped exercise, it should go down and start to return to the normal within 3 to 5 minutes. Emotional stress or situation, of course the pulse would go up. I think we all kind of felt that in our life, right? That test day, your pulse is probably higher, right? So, medications, so some medications can make it go up. The big one though is beta blockers control our heart rate, and so that actually keeps it down and keeps it kind of maintained. So medication, especially beta blockers, which is a heart medicine, is going to decrease the blood rate, or the heart rate. For patients with heart issues or peripheral vascular disease, there is an effect typically for hypotension. It can cause a higher rate, and then the hypertension can cause a lower one. Okay. And then physical condition. So the better in shape you are, the lower your heart rate should be. Right? Assessment of pulse. The most common site is going to be the radial or carotid artery. If you can't access the radial, you should go to the temporal or the carotid. Carotid's probably the easier one to find, so I would do that. You can often describe the rate, the rhythm, and the volume as well. There's other places to find the pulses in the lower extremity, so the inguinal, the popliteal, the tibula, and then pedal artery site as well. We're going to go over those more in detail in lab. Okay. Remember that at rest, some patients are going to have tachycardia, which is when the pulse is fast, and then bradycardia, which means that it's slow and slowed down. So, like I said, there's different ways to kind of describe pulse. So you could say it's strong and regular, which means the beats are really consistent. You can have irregular, where you have like a strong one and then it's kind of weak. It could also be skipping a beat as well, and that would be considered irregular. Thready indicates a weak a beat or an irregular beat to it as well. Like I said just a second ago, tachycardia is when their heart rate is high. It's above 100, and then bradycardia would be less than 60. these are all the locations that you can, assess the pulse at. We'll go over them in lab. The easier ones to find are gonna be, B, the carotid, C, that, C, brachia, it's a little tough, but D, the radial one is an easy one to find. Then the leg ones, I typically would tell you that, G, the dorsal pedia, or, I don't know. I personally think it's easier than the posterior tib, but some people do better with posterior tib. So the reason you want to assess the lower extremity is if they were concerned about circulation, then you probably need to assess it, okay? So swelling, and especially if they have swelling or they have color change in the skin, we're gonna make sure that we assess it, right? And then if we found that we were having trouble finding the pulse, you should then go, I usually, personally, if I'm checking somebody, I start distally and go centrally. And the reason I do that is if I find it distally, then everything else up down the line is good, right? So that's the way I go after it, personally. But there's no wrong or right on, oh, I gotta start distally. So I just figure it saves me time, okay? Abnormal responses. So our pulse rate should, if it's slowly increased during activity, that would be a concern. If the rate does not increase, that is a concern. If pulse rate continues to increase or decrease as the intensity of the physical activity plateaus. So if they're staying at about the same level of intensity and their heart rate is going way high or it started to drop on us, we should stop and reassess them, okay? If the heart rate slowly declines as the intensity of the exercise declines or terminates, so if they're staying really high and you stop the exercise and they're not recovering, that we need to monitor them and then talk to the physicians about it, okay? Heart rate that does not decline with intensity, then heart rate that declines during the exercise before the intensity of the exercise declines. So again, they should steadily go up just like the exercise went up, right? And they should kind of stay with where the exercise is at. That's why I always think that they should be paralleling what we're doing in intensity, okay? The rhythm of the pulse becomes irregular during or after exercise activity. That's also a sign that something's up as well. Remember that if you don't see, if you know they have a cardiac history and you don't see a change in their heart rate, I would definitely ask them right off the bat, do you take medicine, do you take a beta blocker, right? And see if that's the reason that they're not changing before I start calling the physician. Pulse oximetry. So this is going to measure your oxygen saturation. Our patient should be, if the device should register between 70 and 100. You put it on the finger. You're supposed to remove the nail polish. If you work in an ER, they do remove the nail polish usually to make sure they're getting an accurate reading. For our pediatric patients and sometimes our geriatrics, if they're confused, you'll see it donned on the earlobe. I've also seen it donned on and taped on the toe as well for our little pediatrics. So anyway, they should be running, we should all be running between 90 and 100. Really 95 to 100 is where we ideally should be sitting. Hypoxia is when the blood oxygen level saturation is decreased below 90. Make sure for our COPD patients, they run lower. So they are usually allowed at 88 to 92 is where they sit at rest. And so usually those doctors you need to talk to about how low they're allowed to go. I would say I don't really worry if they drop. If my patient started off and he's at 89 and he starts walking and he drops a little bit like 87, but he has COPD and he's used to it, I go by his symptoms. and how his rate of perceived exertion, okay? Because they've managed it for a while, they have COPD. So I'm a little bit more liberal on what I allow my COPD patients to do, just because they have to learn to work with what they have, okay? So, but you should actually talk to your physicians and see what they are okay with. Some of them are very strict and they say stop at 88 always. My problem with that is sometimes that means that patient will like literally never be able to do anything. So, but we are supposed to stop at 90%. If they drop below 90, I'll be really honest, you guys. I worked for 2 years with COVID patients. There is no protocol for COVID, right? We kind of were like, just good luck. Here's a COVID patient, how to help them. And so you learn, what I usually did is I monitored them when they felt like I treated them more like a COPD patient, and when they told me that their rate of perceived exertion was like a 6, 7, or 8, and they were working that hard, I stopped them from their activity, monitored their recovery period, to be able to see how fast they could get their oxygen back. And then that helped me change and decide what activity I would allow them to do. So an example of that would be if I had them up walking and they dropped to, let's say, 84% and they're at 7 or 8 on how hard they're working. If I have them stop and they recover within 30 seconds, then I know that walking wasn't too strenuous, their body recovered. But if it took them 5 to 8 minutes to recover, then I know I need to stop them way before. The problem with COVID patients is most of them have gone from having no history of lung issue to all of a sudden abruptly, and they have no idea how to kind of self-monitor. Yes?
Do you notice a difference between long COVID patients versus like current COVID patients who are like currently infected?
So, the long COVID, it's kind of the same strategy. Typically, they've started to live with it for a little bit, but you have to teach them energy conservation is what I really learned. So you have to teach them, instead of trying to walk 200 feet, I need you to stop at 100 feet and just stand here and breathe, catch your air, and then walk the next 100. So if they have just been diagnosed with COVID, you're just kind of really trying to feel out what their boundary is. When you get to the long COVID, the long haulers, you're really trying to teach them strategies to be able to go back to life, okay? Technically oxygen is a drug, and so you're supposed to not adjust oxygen in our scope of practice. We're not supposed to be doing it unless the physician wrote an order and it says. So a lot of physicians, when COVID happened, they were like, we're not in the room, we're not doing rehab, whatever, you do what you gotta do. You keep them above 90. So if I needed to dial them up on oxygen and go from like 3 liters to 6 to keep them at 90 to be able to work out, I was allowed to do that. So it's gonna kind of be facility specific on how much leeway you guys get with the oxygen. So, so the short answer of that is it's kind of the same goal, but with the long COVID, you're really having to teach these people how to go back to life, and teaching them how to stop themselves before they get exhausted so that their recovery time isn't as bad. The really cool thing though is I have had the opportunity to work with some long-term or long haulers, and they do eventually get off of oxygen, because that was like the number one question I always get is, am I ever going to get off this? Am I going to have to? And I had some young people that, I remember a 26-year-old, a 30-year-old, they were both like, I don't want to take this to work. I want to, they do eventually get off of oxygen. So that's one of the good things. So now we're even starting to, I don't know why we weren't doing this in the beginning, but it seems like now we're starting to send them to pulmonary rehab as well. And so that helps too, but sometimes we're doing that rehab too, like they don't get to go to pulmonary rehab as well. So it's a good question though. All right, well, I've diverted. All right, so blood pressure. This is the physiological variable that reflects the effect of the cardiac output, the peripheral vascular resistance, and other hemodynamic factors. I'm going to say this word once today. I'm going to say it once and laugh. And I'm just like, this is ridiculous. Manometer. Who comes up with these words? Like, really? Like, I was like, it's a blood pressure cuff. So we're going to call it blood pressure cuff now, because none of your patients are going to know what that's called either. So we use a blood pressure cuff, right, to take indirect measurement of the pressure inside the artery, and it's caused by the flow, the force that is exerted by the blood against the unit, the vessel walls as well. So remember, the systolic pressure is the blood pressure at the time of the contraction of the left ventricle. It's not the pressure in the ventricle. It's actually the pressure in the aorta. All right. So a lot of people think it's the actual inside of the heart, that ventricle. It's not. It's really the pressure of the blood as it got pumped out into the aorta. Okay, that's what the measurement is, and that's the systolic. All right. Systolic pressure is at the time of rest, what that pressure is in the aorta. All right. Blood pressure is affected by blood volume, vessel compliance, and vessel size. Right? Kind of makes sense. If you got a lot of plaque and stuff, that vessel size is going to be smaller as well, so that's going to make the blood pressure change. Okay. The difference between systolic and diastolic pressure is called pulse pressure. When the ventricle of the heart contracts, the contraction pushes the blood into the aorta. Like I said, when the ventricle relaxes, you get that the heart chamber will relax. And then that second pressure is the diastolic. Okay, so just make sure you know the difference between those two for sure. So people with hypertension are more susceptible to coronary artery disease, right? Having a stroke, having peripheral vascular disease, or congestive heart failure. Factors that contribute to hypertension would be obesity, physical inactivity, excessive use of nicotine, alcohol, salt. You'd be shocked at how much salt can actually really drive up people's blood pressure, especially people that are already kind of borderline unhealthy, like they have like a kidney issue or something else. The littlest thing with excessive salt can really drive up that blood pressure. Okay. Diabetes, and then advanced stage kidney disease, like I just talked about, can all make you have, or in diet can all make you have be more susceptible to having hypertension. Okay, hypotension is when our blood pressure is low. We might feel dizzy, have an episode of passing out, syncope. It is not life-threatening. However, if you have a ton of problems with falls because of it, then you've got other issues, right? So we could get a head injury or broken hip or something else. So we do still worry about hypotension. Most people do not show signs of hypertension, and it's usually undiagnosed for quite a while before people find it. That's why your annual visit to the doctor is so important. These are all the sounds that you're going to hear when you're taking the blood pressure. So the first one is going to be like very faint, kind of sounds like maybe there was a tap sound. It's usually very light, but that is considered your systolic right then. Then you'll get hearing like more of a swoosh sound with your blood pressure, and then you go into more of a crisp, loud, like you're like, yes, this is it. I know it. I hear it. Okay, that's the 3. Number 4 is it becomes kind of muffled, and then 5 is when there's no sound at all. Okay, you might hear. I have never heard any PT refer to blood pressure sounds before. Maybe nursing. You might hear them refer to it, but I've never encountered it before. These are considered the acceptable norms per your book. However, I don't want you to memorize these, okay? They're in the lab handout. I wrote them in it's the first part of the handout. I think it's on page 9 if I remember. These are the old numbers. These were outdated a couple years ago, and so I included the new one. I even wrote on it, this is the new numbers for blood pressure. I want you guys to learn those, okay? Learn those instead. So don't learn the stage 1, 2, and 3, and 4, right? So assessing blood pressure, the most common site is going to be the brachial artery. You're going to use that stethoscope, the blood pressure cuff, have the patient, they can be sitting, standing, or laying down. It doesn't matter. The biggest thing is you don't want them to be moving and you want the arm supported. We don't want them to be holding the arm up because the contraction can make a higher reading than really is accurate, right? So we want them to kind of relax the arm. So a lot of times we need to put a pillow. The other thing is, people love to like, as soon as you put the blood pressure cuff on, then they want to start talking to you and they want to start moving. And we're always like, what are we doing here? So you got to remind the patient, even sometimes hold them and say, listen, I need you to not do this. So last week I went and saw one of the second years. He's trying to take the blood pressure. The guy has not spoken the whole treatment, and the patient immediately started talking as soon as he was trying to take the blood pressure. And he's like, the guy starts moving. I'm like it's exactly, they will always do that. I don't know if it's like prompt to you or it's what have you, but have them keep the arm still, give it support of something, like put it on a pillow or what have you so they're not contracting, okay? If you have to do it standing for like orthostatics, if they're standing by a walker, I usually ask them to literally put the arm, just rest it on there so that they are kind of cued to let it just relax, okay? All right. So the cuff size matters. We want to make sure we use the right cuff size because if you get one that's too small, it will actually give you a higher reading than it should. If you use a big cuff and take blood pressure, you'll get a lower reading than you should, okay? So make sure you use the right cuff size. The width of the bladder, so that's the width of the blood pressure cuff, should be 40% of the circumference of the middle point of the limb, okay? Most of them are kind of marked. You'll know if it's too small because they'll kind of un-Velcro, they don't want to stay, you can kind of tell. That's one of the ways to know. And then the bigger ones, you'll kind of just know. You get this skinny little sweet old lady, and you put the adult size on, it's probably too big for her. You might need to go down to the medium one, okay? All right, so MAP is something you're going to hear about. MAP is the average pressure that occurs during a single cycle. So what that really means is, so to calculate MAP, it's 2 diastolic, 1 systolic, and you divide it by 3. You don't have to know that number. I just want you guys to be aware of that MAP you're going to hear it's the average of the blood pressure basically. And so a lot of times in the hospital now, they don't always, if they're taking the blood pressure every 15 minutes and the patient is really critical, the physicians usually have a parameter that they say is okay to work with the patient as long as their MAP stays within this number. So definitely it's contraindicated for us to work with them if they're below 60, okay? So, but a lot of times, like I've been in hospitals and they'll say, as long as he's running between 90 and let's say 105, you can work with them. And they're talking about the MAP, they're after that average. On a screen, it will literally say not only the blood pressure, but it'll say MAP as well, okay? So you don't have to sit there and calculate it. If you take somebody's blood pressure and for some reason need to take it again, just make sure you deflate the cuff all the way. You're supposed to give them a full minute of rest before you start it again. The reason for that is to allow the extremity to gain back full circulation all the way distally and all the way proximally. So 30 seconds is not considered adequate. when you're trying to figure out, another quick way for the cuff to make sure you get the right size, it's supposed to be a 2-to-1 ratio, meaning the length, is 2 times the width, okay, for the patient. So we'll go over it, in lab as well. You'll kind of notice it too. I'll show you a pediatric one and you'll be like, oh yeah, that's way too small for us. So what things, affect blood pressure? Of course, our age. Younger patients, should have a lower systolic and diastolic versus the elderly. Physical activity, the systolic should, gradually increase with the exercise. It should plateau as the exercise plateaus, and then gradually decline as the exercise intensity declines, okay? The emotional stress can make it go up as well. Medication, depending on what you're on. My dad had had a hard time in the spring with hypotension. So we were actually, it was the first time in his whole life, in like 25 years, that we took him off his blood pressure medicine, that we were lowering it. We were actually driving his up. We were giving him stuff to drive it up. So there is medicine for both ways. So it depends. So you just have to know whether they're using medicine for or blood pressure control as well. Blood volume, if you have decreased volume, it could increase, there could be an increase in the volume as well. So if you're dehydrated, right, your volume would be less, and so your blood pressure will be lower, right? Versus if you're hydrated really well, it should be higher. So just remember that for dehydration. That would be, again, somebody that's like hypotensive. All right. Factors that affect blood pressure, this is a continuation. Size and condition of the arteries, right? If they have a coronary artery disease, how big the artery size is, that's the lumen. That matters as well, right? So if it's wide open, it should be less than if it was closed off. Like if it's constricted with coronary artery disease, they're going to have a higher amount, right, of blood pressure. The arm position, that matters. Whether the muscle's contracted when you're doing it, the side of the measurement can affect it too. Typically, the left arm is considered more accurate than the right arm because it's closer to the heart, and that's why. And then cardiac output. So systolic blood pressure increases with the cardiac output as well. Okay. So here's a nice little diagram from your book of how to do it. We're going to go over it in lab. Just remember the arm position is important for manual and mechanical. So a lot of facilities use the mechanical devices. You're going to learn in lab how to do manual, okay? Because if you can do the manual, you can do the machine, right? Because the machine is the same thing. You just slap on the cuff and you push a button, right? So I would rather you learn manual and know how to do it, so that if you don't, sometimes patients, the machines can't regulate and can't hear the blood pressure, and so you get a really skewed reading or an error message, okay? I've found the people that are really light, it's faint, you can't hear it well, the mechanical machine does not pick it up well, so it'll be way off. It'll either be extremely high or extremely low, or give you an error reading, okay? So just remember, it's really important where you keep that arm. Cuff placement does not need to be precise for the mechanical machine. It needs to be a little bit more precise for manual, which kind of seems weird, but the machine actually, if you have it turned just slightly, it'll still pick it up just fine. Also, the other thing is, the machines are usually more sensitive to movement than we are when we take it manually, okay? So keep that in mind. If the patient was moving around a lot and you get a really high reading, it's probably because of that. You need to stop the patient from moving, okay? There is such a thing as finger units. We don't recommend them at all. They're not usually accurate, especially if you'll have patients that ask you, should I get a cuff for my arm or should I get the wrist one? Everybody loves the wrist one because it's easy to put on and they can usually do it by themselves. It is less accurate than the arm one, but there's a trade-off, right, on whether they can do it themselves. There is a finger one. The finger ones are not accurate at so I never recommend that. Right. Abnormal responses, you need to know these. I would tell you to know these for tests, but also to know them for your boards. I think a lot of them kind of make sense, right? The systolic pressure should not rapidly increase with activity. If it doesn't increase with activity, that's another sign that something's up and we probably need to stop. Systolic pressure that increases or decreases with intensity of the exercise, or plateaus with the intensity of the exercise. So if it kept going up and we've plateaued them on their workload and it kept going up, we have a problem, right? They should mirror what our activity level is doing, okay, with blood pressure as well. So any of those kind of changes that don't seem quite right, we need to stop our treatment, let them rest, and reassess them. So systolic pressure that does not decline as the activity declines, systolic pressure that declines significantly below the resting level, that's a problem as well. Systolic pressure that declines during exercise intensity, and the rate, so systolic pressure rate or amount of systolic pressure increase excessively during the exercise. And then the other big one is diastolic pressure. Increases more than 10 to 15 points during the exercise. So that is across the board. If they increase more than 10 or 15% or degrees on that pressure for diastolic, we need to stop therapy. Something's up. Their workload is becoming too much for them. Right? So diastolic pressure may not change very much. Sometimes it will even slightly decline. When I say slightly decline, I'm talking slightly, like 1 or 2 points, okay? That's actually considered okay. Always kind of freaks me out if it happens, so then I get like really serious about monitoring them after that. But it's actually considered okay that diastolic drops just a hair when they're working out, right? The other hard stop for us would be if the systolic reading ever went above 250, we would absolutely need to stop therapy, right? So respiration. So respiration is 2 components. It's the inspiration and the expiration cycle. So 1 inhale, 1 exhale is considered 1 cycle. So when you want to go to measure this, you're going to only measure really inhale, okay, when you're doing your count. Patients should run between, adults should run between 12 and 18 is the average. If they're above 20, that's considered abnormal, and you need to make sure the physician's okay with you seeing them if they're running that high, because they're pretty stressed. If they're having to breathe that much, the cycles are coming that fast, they're labored usually just sitting there at rest, okay? If they're below 10, you should also talk to the physician, because you want to make sure that they're okay to be seen for therapy as well. All right. Kids, of course, breathe about they're usually their cycles are more, and then the babies are 30 to 50. I don't know if any of y'all have kids. A couple of you do. I remember when my kid was really little, how quick he was breathing. I was like, okay, I think this is okay, but it seems like a lot for us. So anyway, it's fine though. Assessing respiration, we just want to make sure that we want to try to do it when they're not paying attention. Your reading will be much more accurate if you can do it when the patient's not paying attention. You can watch the rate, the rhythm, and the depth and see if they're using their diaphragm or they're using their accessory muscles, right? So that's part of that depth. If they're having labored breathing, we want to document that. If they're having episodes of trouble or stopping breathing for like apnea, we want to monitor that as well. At that point, if they were stopping breathing or missing a breath, I would be stopping therapy anyway, okay? And then if some patients, especially our cardiac patient, they'll have problems with laying down, and it causes increased labor breathing. So a lot of times patients need to sit up. You'll see this a lot in the hospital. You'll see it in home health, and you'll see it a lot in rehab as well. They can't lay flat on the bed anymore, so they need a wedge and stuff because they're gonna feel short of breath. It's usually because of cardiac and pulmonary issues, okay? So the best guide or way to do respiration rate would be if you can do it while you're taking the pulse. So just act like you're still taking the pulse and watch the respiration rate, okay? So that's the best way to catch it so that the patient is not aware that you're counting that, because they will literally change their breathing if they know that that's what you're watching. All right, I think it's like a subconscious, we all do it. Like, I'm like, oh my gosh, they're watching me. Like, you just automatically do it, right? So try to do it when you're doing it with the pulse. Usually if I'm gonna count it, I just act like I'm still counting their pulse when I'm doing it. Your book gets into listening to the sounds. We're not gonna get into that. I'm not teaching, or not in this class at least, we're not getting into all the different sounds. I just want y'all to be aware of, there's different sounds that you might hear during breathing depending on the location. We would discontinue therapy if they are starting to feel short of breath, they're having like an asthma attack. If you start to hear like rattling, start to hear crackling, things like that, we're gonna stop our therapy, okay? Just because that's abnormal and we shouldn't be hearing all those, all right?
I'm pretty sure I have a recording of like the very beginning sound of that, like that indicator,
Yep.
the A, like they're breathing wrong.
Yeah.
And then a full blown strider,
Yeah,
right, the final, whenever we had to keep track of it for like the doctor and stuff.
sure.
They're like hunting ticks and
Yeah.
it's still rolling.
And it just depends on how long the patient's had it. Like, it's your son, right? So some people they know it's starting to come, and so they'll tell you that they have to stop, and you just need to, honor that and know that you need to stop. Some people they're not aware. Like maybe they just got diagnosed with bronchial or bronchitis, right? And so all of a sudden they've got this really raspy breathing that starts and then they're coughing, they're going into their coughing spell as well. So if you're starting to hear new sounds that they weren't really doing when you first started, you need to stop. Make sure you're checking their oxygen and then reassess and let them see. So just know that wheezing is usually from like COPD or asthma. Sometimes it's a higher pitch sound too. Sometimes you can literally hear them inhale. You'll hear that sound. And then your COPD patient, they're always our outlier on stuff. Our COPD patient might do it at rest. Sometimes for them, they can control it well enough, and you teach them, we'll talk about pursed breathing next semester, you teach them strategies on how to slow down their breath to be able to walk the distance. So we kind of have to, if they're somebody that has COPD, you kind of have to keep in mind that they might always have a little bit of like a wheezing sound to their breath, okay? The fifth vital sign, it should really be symptom, not sign, is pain. Remember that pain could be an unpleasant sensory or emotional experience. Remember, it's a subjective thing, so everybody's pain tolerance and pain it could be multiple things, right? It could be social, it could be, it is affected by your spiritual emotions, all those things. And so just remember that we do need to take that into account. If they're complaining of pain, pain is abnormal. When you're sitting here, you guys might tell me that your shoulders hurt or your neck's hurting or something like that, but truly pain is not a normal thing that we should have in our life, right? So if they're complaining of pain, we really need to take that into account. We need to assess what's causing the pain, use the characteristics of how they describe it to assess whether our treatment, like is there something that's causing it, like the chair or where they're sitting or what have you, and whether we need to adjust our treatment because of the pain. most of us know pain assessment scale, we've been asked this. Scale to 1 to 10, how bad your pain, you got a smiley face. So there's visual and verbal scales for this. Really were mandated in 2004 by the Joint Commission, tells us that we have to assess this. You guys, when my first job, my first career, 2008, I'm at a huge hospital. Joint Commission shows up. Of course, they came right after me because I'm the newbie, right? And so I had documented pain at the beginning of my treatment. I documented pain at my end of my treatment, and I got questioned for like 15 minutes on why I did not assess pain during my treatment while the patient was walking. So Joint Commission is crazy about pain. So document it a lot in your notes, okay?
Is that due to the opioid epidemic that's stemming from it, like?
I think what it really started with was, all right, so I'm kind of like lumping all of healthcare into like one big pot, right? And it's hard, you guys, because literally every day, everybody's gonna tell you their problem and their complaint. So you hear that 15 times and you kind of get used to it, right? So then it's not a big deal. If everybody comes and sees me and they're complaining of a problem and a pain, you kind of get, everybody has it, right? And so I think we weren't addressing pain in healthcare in general. And so the Joint Commission really went after that and said, you guys can't ignore this. Like, so when somebody tells you they have pain, it's an indicator that something's up. They should not be in pain. But that is probably one of the number one reasons that we go and see our doctor, right? It's because we're having pain. So I think it's easy to, I remember when I did outpatient, and I remember I went home one night and my husband said something to me, and he complained about, I don't know what was hurting him, and I was like, I don't care, everybody's hurting me, like, because I heard it for like 15 patients that day. And so I think it's easy for us to kind of get just compliant and just kind of get used to everybody complaining of pain. And so I think as a healthcare system, we weren't addressing it, and that's why Joint Commission got so crazy about it. And they're still very, that is the number one thing they look at when they go into a place. They look at safety and they look at pain and how we're managing it. So there's kind of been a shift away from medication for pain, and then whether we're documenting and showing, just in like the last, I'd say 18 months when I've been working at the hospital, they want us to talk about pain and then how we're using ICE or heat or physicians to minimize pain, and then follow up with that and give an example if it decreased, stayed the same, or what have you with ours. So I've seen that a lot working in the hospital lately. Like they want us to document the positioning change, help them, or it didn't. So final notes. We're going to talk about it later, but I want you guys to already be introduced to it. It is talked about in the book as well. Rate of perceived exertion. There's a ton of research behind the Borg scale. So this is, we all know 1 through 10 for pain, right? So basically they did this 1 through 10 for how hard you're working. They have correlated, they have put people on the treadmill. They didn't show them their heart rate. They put people on the treadmill that had COPD, they had heart issues, what have you. They were able to show that the stress level, so let's say I want them to work out at 6% or 60% of their max heart rate. People could come and say, if they were blinded, couldn't see any of their information, if I asked them to go to the level of a 6 out of 10, they would, and they would hit the 60% on their heart rate, okay? So we now use this for like our cardiac patients that are on that beta blocker. We can use it for our COPD patients. So this scale is fantastic. It's underutilized in healthcare. You will have to be somebody that has kind of like even talks to your CIs about it. But using the Borg scale is very important. It's actually, remember, a lot of times patients aren't going to be able to monitor maybe their oxygen at home or their heart rate by themselves, right? So if you can teach them to use the scale, I want you to work out. I want you to be walking through the house or outside at between a 6 and an 8. They get that and they can actually do that. Okay, so it's a great way to help them start to self-monitor as well. Okay, I'm in a quick bind, I literally just ask my patients, scale of 1 to 10. 0 or a 1 is sitting, a 10 is you're sprinting and you need to stop sprinting in less than 10 seconds or you're gonna kill over. Where are you? That's my answer, and I want their feedback, and I go with that, right? Because it is very valid. There's a ton of research behind it. All right, are there any questions? All right, you're free to go.